time of day, good time for a joke. I don't have many, and mine are all kid jokes, but the only one I can think of for the moment is what did one eyeball say to the other? Between you and I, something smells. So, sorry. Okay. So this lecture, I wish Glenn was sitting here because really the subtitle of this lecture could be What Glenn Did Right and Steve Did Wrong. A lot of these ideas just come over the years of having done different mission trips and training different people and learning things myself. But some of the most painful lessons came last May when I went and did something I thought would be a no-brainer. I went down to a residency program in a developing country and they asked me to come down and train some of their residents in MSICS. And I said, well, this will be a no-brainer. Boy, they're all set up. They got great ORs. They got a residency. They're partially trained. They already have some MSICS experience. I've trained people from scratch. This will be a walk in the park. Great. And it was a very difficult experience for me and for them. So, and there was now, in retrospect, looking back, there were a lot of lessons learned. I came back, and Glenn and I kind of talked by phone and compared notes, and he had done something similar, but quite different in the same place a few years back and had a different experience. So some of this will kind of come from that, so you learn from your pain as well. This quote I just wanted to throw up as just something to kind of get us thinking. This is not only going to be about training and learning, but it's just some philosophy on MSICS as well, and we've heard some comments about that along the way. This was a quote from David Park at the AAO meeting in the opening ceremony in 2011. And I don't remember what else he said. But one of the phrases he said is, we have been given the responsibility for the world's eye care. And off he went talking. And my mind just stopped right there. And if you think about that for a minute, that's a pretty profound statement. Because we're it. The plumbers of the world are not going to fix cataract blindness or other forms of blindness. The internists aren't going to do it. The lawyers aren't going to do it. It's us. If we don't do it, nobody's doing it. So, and given the responsibility, that kind of implies, by whom. So, too much has been given, much is expected, as others have said. So, just something to kind of resonate on there. So I want to talk about a few things. One, factors involved in creating a more predictable learning experience, both for the trainer and trainee. Preparation for MSICS training experience on the part of both the trainer and trainee. And then common causes of difficulties. So this is just some of my international experiences I've had, short-term and long-term. Been involved with both kind of projects. The long-term wise to train a national ophthalmologist, and he responded just beautifully. Actually worked with a few in that kind of capacity, and then some U.S. training experience with U.S. residents as well. So something I'd like to do, and yet it's not always the easiest thing to do. So some things to think about up front is, where do we learn and teach MSICS? I mean, we're learning it here in a classroom, but to really do it, we typically do it outside the United States, and that introduces some challenges for both the trainer and the trainee. So we're not in our home setting, our home ORs. So understand your setting. You have new instruments, scopes, viscoelastics, as Stan had mentioned. Are you entering a long-term fixed site with established protocols and methods, or are you going on a short-term project where you can create much of your own bubble and kind of recreate your own universe in a different setting? And it's good to have, to me, that's a great concept to have. How much of my bubble am I going to bring with me? And then understanding you're working with new people and cultures, and every setting is unique. You can draw from past experiences, and there are some commonalities, but every situation is unique. So this is just a slide to remind me to say we do work together with lots of different people. We work in organizations, many of which have been built up long before we came there. We stand on the shoulders of others. And it's a joy to be able to do that, but there's also challenges involved with that. So this is that bubble concept that I'd like to just kind of throw out there as something to think about. That what is your strategy on a particular project or place you're going to? Are you going to create your own bubble where you're going to control the supplies, the instruments, the staff, the microscope, and pretty much you're in a new setting, but you just put a bubble around you. You pretty much try to replicate what you're used to doing in the United States. Maybe you're doing MSICS instead of phaco, but everything else is very standardized what you want. On the other end, you're going into a site that is completely set up, running on their own. It's a long-term site, and you're coming alongside a national team to maybe train them in a new technique or to help move them along to the next step. And you're not creating a bubble, and you're not creating a bubble on purpose because you want to leave behind a sustainable thing for them. So you can come and create your bubble, but if it's not sustainable, you leave, and when your supplies are gone, they can't do what you just taught them to do. So one's not right and one's not wrong, but just understand your setting, and then, or are you going to kind of do something in between? And that's a very common scenario as well. So what's the right amount of control in terms of creating this bubble? Well, it depends. You want to consider ahead of time the best setting for the beginning surgeon and the trainer. You know, what is the level of control that you want? And what is the preference of the surgeon? Some surgeons are going to be more comfortable having a lot of control. Others maybe, you know, are okay with a little bit more, you know, flexibility. And it's going to vary. So be flexible where possible, but also take control where you think you need to. So some things to think about. This actually was one of the concepts as Glenn and I were talking, that it stuck out to me as a good thing to think about, is to formally have some kind of training prep list that either you have rock solid in your mind or actually written out. And communicate this months before you go to a place, and then follow up a few weeks before to kind of ensure things are going. And the way I usually do it is I'm actually in fairly regular communication, or whoever the coordinator is for that trip is in regular communication over several months. So what is the training setup going to be? Patient selection. How are the patients going to be treated pre-op? Do you have the right kind of microscope, teaching scope, or monitor? If you're teaching, you want to have it set up so that it's a good setup for the student and the trainer. What's the OR setup going to be? Are you operating out of a village in a setup kind of MASH unit, or are you operating in a fixed site with fairly established ORs? What kind of instruments are you going to have? Don't assume they're going to have the instruments you like. Don't assume that if they say they have those instruments, that they're necessarily going to be working when you get there, or they're in good shape. IOLs. They have the IOLs you want. One site I went to was a training site, and I got down there, and they train residents, and lots of them, and do lots of surgery. And I was in the middle of training somebody, and we needed an anterior chamber lens because we didn't have a sulcus. And it was at that moment that I discovered they had no anterior chamber lenses in the entire facility, or I was told in the entire country. Excuse me? No anterior chamber lens? Well, we weren't set up to suture lens, and so we had to leave that patient aphakic. I haven't left a patient aphakic in I can't remember how long, unless it was a bad uveitis patient and we were planning on it. So we left 2 patients in 1 week aphakic because I was training new surgeons, and you're going to use more ACIOLs in those kind of settings. Fortunately, they had an anterior segment specialist who was in the same facility who we could schedule to get a sutured lens later, or a glued IOL, and so they were able to get a lens later. But to me, that was a total failure on my part. As a trainer, I assumed they had that on site, and they didn't. It was just a total assumption on my part, but I'm not going to make that mistake again. Viscoelastic, what are they using? Often you don't find that out till you get there, but if you want more of your own bubble, you might want to bring some of your own, because some of them are so bad, it's kind of like the residents in one place were saying, it's kind of like water. So basically, and that's going to increase your complication rate with new surgeons as well. And then you want to be knowing who's going to take care of these patients after you leave. So the setup, be involved in the planning from the beginning as the trainer. Who will you be training, and how many will you be training? Another question I didn't really have to face too many times until coming into that setting, where there's the residents and the fellows. You're going to be there for a week. Good idea to train everybody? Not a good idea to train everybody. Okay, better to kind of narrow that down, and we tried ahead of time, and the communication kind of broke down, and it became much broader than expected, and that was another issue that we had. But basically identify those who might be the best to train, the most highly productive use of your time kind of thing. Who is in charge for coordinating the visit and the site location? Make sure there's good communication with those people. Who will be the trainers, and are they designated as trainers? This gets a little bit to, like, say, a short-term mission project. Let's say you're going to go on a mission project. You want to learn how to do MSICS, and we're going to go to a place, and we're going to try to do 150, 200 cases in a week, okay? And we have two scopes. And we're also going to screen 300, 400, 500 patients. And this is all going to happen in a week, setting it up from scratch. And we've got 2 experienced surgeons and you're the student. You're not going to do much surgery. The reason is we only have 2 scopes. So I sit down in one, and John's going to be your trainer on that day, and you get 3 cases done. What? We're not going to get through our week's schedule. So if you want to learn MSICS in that setting, talk about it ahead of time. We figure it out. We bring a 3rd experienced surgeon and a 3rd scope. And now you can do 2 cases, 3 cases, 5 cases. We're not depending on you for volume, okay? That then becomes a much better, and they have a teaching scope or a monitor with it. It becomes a much better learning experience for the trainer, and you're not feeling the pressure to do it. Sorry to pick on you. But, is there a need to treat a volume of patients? Is there a dedicated scope? That's kind of what we talked about. No time pressure for the trainee. And what is the experience level of each party? I liked what Stan was saying in his last lecture. I think it's good to have that understanding. And I think also as a beginning MSICS surgeon, understanding it is a process. It's a lot longer process than you might expect, especially if you're an accomplished phacosurgeon. Just realize you're a beginner longer than you realize, and great to have mentors around until you're really comfortable. So if there's a choice of trainees who should be selected, kind of thinking about who's the best candidate ahead of time. If it's a one-on-one situation, that's really not a question. But if you're going to a group like a residency, maybe you're going to pick the fellows. Maybe you're going to pick somebody who's a local who's going to stick around and maybe wants to work with a program, and so they can train others. You train one person and they stick around for 15 years in that program and train 30 more people. You got a lot more mileage out of that training than you training one resident who's going to take off into private practice and never train another person. So kind of thinking about where you're investing your time. Or a local doctor who's willing to treat the poor, not just operate out of his private practice. And again, you're going to train somebody with more experience or less. I think it depends on the situation, what your goals are, and do they want to learn, why do they want to learn MSICS? Is this just another interesting feather to put in their cap? Or I want to learn this because I want to be able to treat these types of patients. Casting a vision for the person you're training. Someone else touched on that earlier. I think it's beyond the how do I do this procedure kind of training to what is this about and how can we help our fellow man and who are the people who most need our help and how are you going to integrate that into your practice and your life and how can you use this new tool to do that. This concept of exploration came from a conversation Glenn and I had about maybe the first, I won't say this is what should happen, but something to kind of consider. Maybe that first MSICS experience is more of an exploration of MSICS rather than an expectation that I'm going to go for a 1-week mission trip and I'm going to be an expert. And if I don't come out of this 1 week, I'm disappointed, that I'm an expert and I'm really comfortable. You won't be after a week. Maybe it's more of an exploration of being exposed to something, starting to get a feel for if this is something for you, whether you're willing to commit to the process of actually learning it and kind of becoming more of a master of this particular procedure. And then what are the expectations and can they be met? I think that's good to kind of talk about up front. Patient selection, on a practical standpoint, the more mature cataracts are actually easier to train on. And you probably want to have 2 healthy eyes if you're learning to do it. What are the source of patients and how we'll screen and select them? When we go and do an outreach, for example, we're going to Niger in a month, we've got a pre-screening team that's going to be there weeks ahead of us. So it's much more efficient for us. Instead of screening 1,000 patients, we're going to screen the pre-screen 200. And out of the 200, maybe we'll have 150 cases. So it just makes your experience much more productive surgically. Source of patients, this came up in a residency situation where we brought in an American to be trained along with the residents. And as with any residency, you're pretty protective of your cases, right? So didn't realize till we got down there that the source of the patients for this outside person training was going to be through the residency. So it set up a little tension that probably could have been handled better if we had better planning and communication. And so the outside person didn't get as many cases because she was feeling like she didn't want to take to me from the residents and things like that. So there's subtleties that we all kind of know from our own life experience, but good to kind of work through those things for the better experience. The pre-screening, I think, again, really important to do, saves a lot of time, and the learning value is higher in properly selected cases. And then you want to, of course, review the case as a trainer beforehand to make sure it's what you want. Pre-op, verifying the appropriatenesses of the case, looking at the chart, examining the patient. don't have them dilate all the patients before at 7 o'clock in the morning. And that's one of the problems we ran into. Everybody had to be seen by the attending doctor to prove the case in a dilated state. Well, we were operating till 6, 7 o'clock at night. So at 7 a.m., they're dilated. So predictably, everybody had small pupils by 1 o'clock in the afternoon, and it made the training much, much more difficult. So that's part of the second point, is confirmed pre-op dilation protocol. I know I've harped on this a few times, but I can't tell you how many problems it causes. And the more experience you get, the less concerned you are about it. But if you notice, even today, there was all sorts of little things that were done to make that pupil bigger. And it just makes your life much more difficult, especially when you're learning. What I do is, if there's been a problem, or even if they're following a good protocol, but there's a delay, we've had a complicated case, I just ask them to put in drops every 30 minutes, the set of 3, every 30 minutes until we get to the OR. And great to have a trusted assistant to oversee that for you. Blocks, decompression, kind of knowing what they're doing preoperatively. Again, the ACIOL issue, don't assume they have the lenses, the powers that you need, and or the anterior chamber lenses, and that you will have a higher incidence of using ACIOLs when you're learning. The setup for the OR is, there's some things you can take for granted there too, and I'll tell you a story here on the next slide of a great example of that. It was my mistake. You want to make sure it's comfortable for the planned surgery. You want to make sure your teaching scope is in order and your monitor. I like a teaching scope better than a monitor, but if you don't have a teaching scope, monitor is a good second best. Temporal versus superior, I think 6F does them another. I think I would start with where the trainee's current technique is. Don't take them someplace new from the beginning. See where they are, see how they're progressing, and if they want to try something new and you feel comfortable and they feel comfortable, fine. That was another mistake I made. I'm a temporal surgeon. In the place I went to, they were all superior. Their trainers there trained them all superior. They heard that I did it temporally. They're all curious. Hey, let's do it temporally. And it didn't go as well as I would have liked. And I was surprised. I didn't think it's that big a deal to switch, but they're new residents, and there was a factor in there that I didn't recognize. It has to do with the setup we'll talk about in a second. Then the instruments, I did check on that ahead of time. They didn't. I use an irrigating Vectis. I like to use a Simcoe. They were using a combination of their phaco machine that was sitting there, so they didn't use Simcoes. They'd never used a Simcoe. And here were these residents going to graduate and go off to their different developing countries, many of them who wouldn't have an Alcon machine sitting right next to them. So they're doing MSICS, and then when they needed IA, they grabbed their IA from their automated thing, and they got all the tubing and expense and everything of running that. And so I brought a bunch of Simcoes with me, and I brought some irrigating Vectises with me. And that was on the positive side of what I did. So that good to kind of know ahead of time exactly what you're dealing with. Viscoelastics, I think quality costs less. So really bad viscoelastics, especially in a training situation, you're going to have more ruptured capsules. You're going to have more extension of if you're trying to do a rhexis. It just makes life difficult. Even putting in the lens implant, as soon as they're not used to working through that wound, they burp the wound a little bit, the anterior chamber goes flat. A little higher quality, doesn't have to be the top quality viscoat, but a little higher quality often pays off in the end with less expenses. Blades too. The blades we were using, that I've used in some sites, are, our dinner spoons are sharper than they are coming out of the box. And I'm not kidding. I mean, it's just incredible. So trying to bring some of your own or trying to get a little bit nicer quality blades are sometimes worth it. First case, I think it's great for the trainer to do the first case. You get a lay of the land. You've done it before, right? So you kind of know what works, what doesn't work for you. How is the scope? How's the wrist rest? Is it comfortable? Can I get my knees under here? In terms of what you're trying to do. And then the trainee gets to see you and your technique, and they kind of see it live, and it's a great way to start, I think. This was a great example of not doing that. I was in a setting where we had many people that they had kind of unexpectedly put in line to get trained. They were only going to be doing 1 or 2 cases with me, and if I did the first case for all of them, they wouldn't have done anything. And they're all interested in doing temporal. So here I come, the expert temporal MSICS surgeon, and I staff them on their first temporal case, and one person after another are going in premature entry. I'm like, these guys are good. Some of them are senior residents, about to graduate. They know what they're doing. One after another, and we're dealing with the iris coming out and leaky wounds and suturing. What in the world? Well, one person was kind of struggling with it and was, here, let me sit down at your scope. I'm going to just help you here a little bit. And I was like, this is terrible. The wrist rest was too high. I couldn't get down. The blade didn't have enough of an angle to it. It was dull. Like, this is terrible. I can't work like this. And here were the students working like that. And so I said, first of all, get this wrist rest out of here. Now I could drop my wrist down. Give me some kind of a hemostat. I bent the blade. Still duller than a dinner spoon. Give me a new blade. So I went from a blue blade to a yellow blade. Only attendings get yellow blades. Yellow blade was sharp. Blue blade came out of the blocks, dull. So the rest of the time I was there, I insisted that I'm the attending and I'm the guest and you can honor me and I'm going to have a yellow blade with my students. And I made sure that the bend in that blade was right, so now the angle was right for their wrist. They had no wrist rest. Voila, success. But it was my fault. I didn't sit down and identify that ahead of time for the students. So some of these little things you don't think about make a big difference. So they begin surgery, seek understanding of where they are, their prior experience, and then add things slowly as you think they're able to handle that. Seek success from the first case, and the needs of the patient come first. That's the saying from Mayo Clinic. It's in our area, and I think it really kind of sums it up well. We want to focus on good surgical technique and not volume or speed. And when you need to, as a trainer, you take over, and that's okay, and the trainee needs to be okay with that. Okay, so this was from Tanzania. Actually, John and I were, I don't know if you went to the beach with me. I don't know where John is, but this was from the rules for monkeys that apply to humans as well. So we have rules, we have guidelines, but we need to be flexible in these settings too. Again, some of the resources that we talked about before. The Irvin manual's been mentioned, the DVD series from Glenn. There's others out there as well. And then mentoring. I know a couple of people have mentioned they learned this from YouTube. That's commendable. There's one gentleman, or one physician, I sat down, gave him a little lecture, handed him the Irvin book, and he took off. This was years ago. Went to Ecuador. He said he did okay. But that's the exception. I don't think that's really should be our rule. I think the idea of learning like this, learning from videos, doing all the didactic stuff you can, but then working with a mentor is, I think, the ideal, where somebody's there with you, taking you through step by step, taking over when they need to. I think the patient outcomes are better, and your satisfaction with yourself and kind of just the whole experience is better, for everybody. So when you're going on a mission trip and you want to learn, make sure there's a dedicated instructor, if possible, the willingness to teach. That's the other part. Extra scope, so you're not pressured, and then have their experienced surgeons to handle the volume if they're in a setting where that's needed. And just be patient with yourself as you learn. These are some of those same things. So next steps, one, just say yes. That sounds really simple and silly, but that actually kind of came as a kind of a morphed quote from Norval Christie when I was a young resident. And he kind of just said, I'm going. When he was young, I'm going. And just say yes. The rest is logistics. So if you want to do missions, you want to get involved with this, say yes. And then the next thing you're going to do is you're going to find a project. You're going to be buying airplane tickets. You're going to be taking courses. You're going to be, you're going to do things, and you'll end up doing it. But the biggest hurdle is you saying yes. Work with a mentor. Pass on your knowledge to others. Kind of getting to be a broken record in this conference, but that's really important. And just enjoy the opportunity. I mean, to restore sight to the blind. It's a pretty amazing thing we get to do. This is what you shouldn't do, write a really wordy slide, but these were just some thoughts I put together, so I'll end up reading them to you. And just more of kind of reflection over the last 24 years of being involved with this is that learning or teaching MSICS requires a sacrifice. It will require your time, energy, travel time away from family. It will cost you financially in terms of time and time away from work and the cost of travel. It can be stressful. It can be humbling. Sometimes you will be sick or uncomfortable. You may go places some people consider unsafe. It will push you and pull you. It will not be convenient. You will need to be committed. So only you can decide if it's worth it for you. For me, it's opened up many opportunities and experiences that have brought great blessing to me and my family. It has given me the opportunity to see firsthand the joy in the face of a patient who has been given the gift of sight and been freed from the bondage of blindness, and the joy of their family members. It has given my family an opportunity to be part of the same and opened the eyes of my children to a bigger world and the joy of helping their fellow man. God has also used medical missions to build my faith in many ways. And that every project is a miracle. I remember thinking of this when John and I were actually on a trip to Tanzania, and we're flying in and out of this village on a helicopter. that had been donated by a single donor in Montana, along with all the hours it took to train that pilot, who was a U.S. internist, missionary doctor who had been moved in his heart to get there. And all these people that came to me, all these resources, and I just realized I'm watching a miracle happen in front of my eyes. So, and I've seen this over and over and over. So it is humbling to be a part of such work. We may be tempted to accept the glory for a patient whose sight has been restored, but I have grown in my appreciation the reality that this is all about God, not about me, not about the surgeon or the medical team. Who created the eye in the first place? Gave me and the team health, skills, resources to travel, and a heart to serve. Brought together team members, opens doors for visas, provides supplies and technology, training, safety, successful travel, opens the hearts of patients, sponsoring donors and organizations, and connects all of these intersecting lines to make something like an eye outreach happen. If you think about all of these dots being connected, the probability of that all happening on its own is fairly remote. The closer you get to it, the more you see the miracle. So do I or we deserve the glory or praise? No, all the glory goes to him. I am humbled and grateful for the opportunity to be a part of serving these patients. What a privilege and what an opportunity. And then most of all, I come at this from a faith standpoint, and I say it's really been an indescribable honor and privilege for me to play even a small role in building the kingdom here on earth through medical missions, to be a part of bringing the good news of Christ to some areas of the world where vast numbers of people have never heard the gospel message even once. To be a part of a process that D.T. Niles once said of one beggar telling another beggar where he found bread. So to God be the glory. Thank you.